So, my name is James Kelly Wolf. Mainly, I wouldn't call it spoken word, and I wouldn't call it rap either, but it's one or the other. I just write like words to beats, like inspirational shit, and draw mediocrely good.
My name's Lindsay Yates. I like drawing and watching anime. I'm originally from Newfoundland. Lived in North Carolina for a little while.
Hi, I'm Courtney Lovelace. I have a huge interest in art, and hopefully I'm going to be going into the nursing program next year.
I'm Laura. I'm a drama therapist who also has training in dialectical behavior therapy and acceptance and commitment therapy. Before then I did a lot of theater work, and I did also some film work and some spoken word, and I also did peer support work.
So my name is Ardith Wynot, and I'm a lecturer in sociology at Mount Allison University, and I'm also a doctoral candidate at Concordia University in interdisciplinary studies and sociology.
My name is Hilary Rankin, and I am the program manager at Langhouse. I support the program team, and the program team does a lot of our frontline work, so working with members. I do the intake, so anybody who wants to become a member, I meet with them and I talk to their clinician, and we come to an agreement as to whether or not this is a good space for them.
Some symptoms of borderline personality disorder, although they've changed between the DSMs 4 and 5 slightly, are definitely around issues of unstable relationships, unstable sense of self, sense of emptiness, suicidality, sometimes difficulty regulating anger.
So with BPD, you start to suffer when you're a youth, when your thoughts and opinions aren't being valued enough. You're in a transition period between schools to maybe post-secondary or out in the workforce. You're in a transition between childhood and adulthood, so you're already in this in-between space, and then you're in between mental disorders. The history of borderline, it's because you bordered on all these other symptoms but didn't fulfill one category, right? That's where the name comes from. So you're in this constant state of in-betweenness, where you don't really fit. And I think that what that leads to is there's a lack of visibility, and I think there's a lack of acknowledgement that youth shouldn't have to suffer. Feeling suicidal and feeling depressed is not a normal youth thing that we should just accept.
People at different times have proposed the idea of calling it emotion dysregulation disorder, because that's more close to what it is, and just all of the things when you think about that will happen when you have difficulty regulating emotions is you have difficulty with interpersonal relationships, you have difficulty with your sense of self often as a relationship with that, how that works in the world, and people often have very low self-confidence and very fragmented senses of self. It's very painful from what I can gather.
With borderline, there's a lot of emotions. It's like being like thrown around, tossed around in like waves, constantly going back and forth. There's a lot of emotion.
I think it's all the same symptoms, regardless of whether or not you're male or female. It'll be the same things surging through your head, regardless that borderline personality might do. So like low confidence tends to come in with it.
A lot of anxiety, so panic attacks, anxiety attacks, a lot of intrusive thoughts.
I do have a lot of trait characteristics. So like getting emotional over absolutely nothing.
Anger, a lot of anger, mostly out on myself.
I think paranoia also plays along with mine.
Depression, like horrible, like can't get out of bed depression.
I also have a diagnosis of PTSD. After I was diagnosed with it, I noticed that sort of when I'm in crisis, it feels the same as when I was like before I was diagnosed with PTSD and in crisis. My PTSD starts acting up. And it's like my borderline sort of amplifies my feelings, my like anxiety and stuff. And because my anxiety is getting worse, my PTSD is sort of like responding to that, making me more anxious, and then my borderline makes that even worse. So like it's sort of like a downhill spiral of constantly getting incredibly anxious to the point I can't even think straight. And I was just like, I just want it to go away. I don't care how it goes away, I just want it to go away. And that's usually how the suicide starts popping up.
You know, if somebody's asking for help, you can't deny them help. Like, I don't know what is so hard for professionals to get about that, but it seems like with BPD, when somebody wants help, it's a bad thing. It's seen as attention-seeking and manipulative and, you know, this kind of like vindictive thing, when really, you know, we're suffering from depression too. You know, we're suffering from anxiety as well.
Somebody's in the crisis, they aren't who they actually are as a person. And I think sometimes you need to, the person they are is in there, in that storm somewhere.
I've been here for 4 years, and it's changed over time. But in general, the things that we always say to people, and our policy around intake is you have to be between the ages of 16 and 29 and have a diagnosis of a mood, psychotic, or anxiety disorder. And so when I first started here, started doing intake, we did not accept borderline personality disorder diagnosis on its own. And sometimes we wouldn't accept it as a comorbidity, like another diagnosis associated with it, because, well, first of all, borderline personality disorder doesn't fit into our mandate. So from that perspective, if someone said, hey, I want to be a member and this is my diagnosis, I would say, well, it's not part of our mandate. Policy shift happened because it wasn't working.
They weren't listening to me. I was talking, about what I was experiencing. They were asking me what they could do for me. So I was trying to explain my experiences and where I was coming from, and I could tell they weren't listening to me. So I got kind of mad, and I was like, why bother telling you guys this? And one of the social workers yelled at me, and he said, do you feel like you have a right to be angry or something? And I think that's kind of a really bad statement to make, because people are entitled to their emotions. You can't tell somebody, do you feel you have a right to their emotions? Because they do. It's a basic human right.
A nurse actually went behind my back and said to my mom, oh, your daughter's manipulative. I mean, what right do you have to go behind a patient's back and talk shit about it? It's one thing cutting off somebody's way to seek help from the hospital, but it's a completely other issue when you actually go to the supports that the patient has to regularly interact with. It's hard enough on the families without a doctor or nurse or any sort of healthcare professional being like, oh yeah, they're just like a bad person, pretty much. Not only is that not in the diagnosis criteria, it's complete bullshit. Who are you, God? Do you know what goes on in somebody else's head? So. I just need to calm down.
Every single one of them has had an experience of going to the ER when they felt that they couldn't keep themselves safe. And they end up getting punished for that, because mobile health crisis workers and ER workers will say things like, well, if you were really serious, you would have done it by now. There's this idea that somehow it's attention seeking. So they end up getting punished for their resilience. They end up getting punished when they're trying to be safe, when they want to feel better, when they're reaching out to kind of get out of those suicidal feelings is when they're being treated badly. They've all had that common experience.
Take accountability for your own struggle to help people who are really struggling, and know that just because someone isn't an easy answer doesn't mean it's their fault or that they aren't helpable. And I think that's that there is lots of hope, and that when clinicians feel they have tools and they have hope, then they feel better about treating someone with borderline, I think.
If you think of it as a job, don't be there. If you think about it as a mission, don't be there. If it's your reason for living, don't be there. If you just want to help somebody and make them smile, be there. For any other reason, don't be there. Because you're not doing anything. You may say the best shit ever. You may get that person the medication. You may whatever. But the slightest fucking amount of negative energy, that person's going to absorb that. So if you're not ready to be there, don't be there. Especially in that field. You don't get paid enough to fuck with somebody else.
I think there's a lot of people in the ER that are just overworked and tired, and when clinicians get overtired, their compassion goes down, And there's a lot of assumptions and generalizations about borderline that people have never thought to question. The clinicians have really old information in their heads about what people thought people's intentions are when they're that dysregulated, and it's just not helpful, because I think there's a real, I think stigma just comes from a lack of empathy and a frustration and not knowing what to do, but it's there because of those things.
But I find a lot of people get really offended when you're like, oh, well, you actually do hurt like clients, and you do hurt people who come in to see you. They may be the best person in the world, not even be trying to do that, but recognize that you're gonna do that, and to own up to it, and then just stop perpetrating it. Even some of the best like asshole doctors, everyone's like, oh, they're a fucking douche. Like, why do you think they're like that? They went about it in the wrong in the beginning. They burnt out. Now they're fucking stuck there. They won't leave because they actually give a shit, but they're killing themselves doing it. There's other ways to help. That's all the system is. Once you burnt out lights, and some are still alive and they burn out.
And I think, in general, we need to not be so emotion phobic as communities. I think that when we're suffering, when we're in pain, we want to hide and we socially isolate. We don't want to make other people uncomfortable with our own feelings. But I think that one thing we can do as families and as communities is for it to be okay for someone who's suffering to still be there too. If you're feeling suicidal, you don't have to stay home. Why not feel suicidal at school, at least surrounded by your peers? And I think that could be a really interesting experiment in looking at how we can negotiate our emotional boundaries, but make sure that those who are suffering aren't so isolated.
I didn't have some great experiences with some of the nurses. Some of them I did, though. It was good and bad. There were a few of them that just would actually listen to what I was trying to tell them. I found they were really like empathetic, and they treated me like a person, which that should be the norm, but it's not.
And like Dr. St. John, if it wasn't for her, well, probably would have ended up dead at some point. Or at very least, she got me with the services I needed for that time.
We had 2 members come in and gave all of our staff, including the fundraising team, a really terrific, impactful presentation around the diagnosis of borderline personality disorder, what it's like to live with it, what it's like to be, have people treat you differently, and the stigma around it, and ways that we could have conversations, ways that we can support people. Members who have that diagnosis came up with a way to make intake easier and more supportive and kinder. So that meant that people with members who have borderline personality disorder became much more engaged in the process of intake and becoming a member at Langhouse. And it's it's been remarkable, the difference.
I think it's really important that young people with this diagnosis have a voice, and I think it's a voice that is really needed in the public discourse about stigma, because often there's a hierarchy of diagnoses in anti-stigma conversations. We have to acknowledge it before we can change it. We don't even acknowledge that there's a hierarchy and there's like a power differential in treatment. Like, we don't even acknowledge that in lots of spheres. So I think we have a long way to go to acknowledge what we need to acknowledge to make the change, but I think it is going to be changing inadvertently or intentionally, whatever, it just through the very, nature of integrating more DBT and compassion-focused models into the system. I think that will, by nature of the biosocial model and having people re-educated into what borderline is, I think that will really help a lot of clinicians to remember their own compassion and not to use that quick shorthand to borderline equals difficult.
The DSM is hundreds of different disorders that, people like me, other people experience, and we need to talk about those, because those are the ones that are viewed in society as scary or, bad or anything like that. We talk so much about anxiety and depression, but yet we've got bipolar disorder, we've got personality disorders, there's a lot of them. We've got schizophrenia, we've got psychotic disorders, psychosis, we've got eating disorders, we've got dissociative disorders. There's just so many other ones that we can talk about, but they always they always stay in the dark because we don't talk about them. they need to be talked about more.